Welcome back. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with our Shaw. Today, we're going to reframe how we look at medical coders and clinical documentation improvement, or CDI specialists. We're putting you in a completely different light. You really aren't just administrative staff. You're actually investigators. Your job is to meticulously solve this massive medical record puzzle, and you do this to ensure two critical things: accurate hospital payment and a true, honest clinical representation of how sick that patient actually is. So, let's kick things off with a high-stakes question to really establish why your investigative work matters so much. Why is meticulous medical documentation absolutely critical to a hospital's financial survival? Well, the harsh reality is that healthcare facilities simply cannot operate on vague assumptions. If the clinical picture isn't crystal clear in the medical record, the reimbursement isn't going to cover the massive resources that were actually spent saving that patient's life.
And the answer to that high-stakes question, it lies right here with the IPDRG. This is the bedrock, the foundational framework of the Inpatient Prospective Payment System, or IPPS. It basically sets a fixed prospective payment for every single patient stay. By grouping patients into statistical categories based on the resources we expect them to consume, the IPDRG dictates exactly what the hospital gets paid, and it does this long before the patient even walks out the door.
Okay, here's our roadmap for today's investigative journey into inpatient medical coding. We'll start with the IPDRG funnel, then tackle principal versus secondary diagnoses. Look at the power of CCs and MCCs, discuss CDI and queries, run through some high-stakes coding scenarios, and finally, wrap up with procedural nuances and updates. Section 1. The IPDRG funnel. So, how exactly do thousands of incredibly complex diagnoses get filtered down into just one single payment category? It's all about this highly structured funnel logic used by the IPDRG grouper software. First up, it factors in patient demographics, age, sex, discharge status. Then it grabs the principal diagnosis and assigns it to one of 25 major diagnostic categories. Next, we get a medical or surgical split, basically was a major operating room procedure performed. And finally, it determines the ultimate severity tier by hunting for any complications or comorbidities.
Moving on to Section 2, Principal versus Secondary.
There is a huge, sharp contrast between two terms that people mistakenly swap all the time, and honestly, it causes some of the most costly coding errors out there. The primary reason for admission is just the clinical focus on day one. It's the chief complaint, like chest pain, and it's mostly used for administrative tracking. But the principal diagnosis, that is the condition established after study to be chiefly responsible for occasioning the admission to the hospital. And make no mistake, it's the principal diagnosis that actually dictates your major diagnostic category. Now, for secondary diagnoses, the key takeaway is that they only drive up reimbursement if they meet some very strict criteria. They have to require clinical evaluation, therapeutic treatment, or increased nursing care. But more importantly, the POA, or present on admission indicator, is literally make or break here. Conditions that weren't present on admission, like say a hospital-acquired deep vein thrombosis, will not increase your DRG weight. Even though a DVT is a major complication, because it wasn't POA, it's going to trigger a quality review rather than dropping a higher payment.
Section 3. The power of CC/MCC. Every single case gets evaluated against this triplet structure you see here. The presence or absence of these secondary codes is what determines your final payment tier. Down at the bottom, we have the basic DRG without any CC or MCC, which yields the lowest payment. In the middle, a CC, a complication or comorbidity like malnutrition, adds a layer of moderate severity. But when you identify a major complication or comorbidity, an MCC like septic shock or acute renal failure, that significantly shifts the patient's severity profile and maximizes your reimbursement.
To really put that into perspective, let's look at this number, 1.9015. Documenting a powerful MCC, like diabetic ketoacidosis, alongside a principal diagnosis of sepsis can literally double a hospital's relative weight for that case to 1.9015. It absolutely proves, without a shadow of a doubt, that finding precise, specific words in the medical record has a massive, tangible financial impact.
Section 4. CDI and queries. So what do you do when a provider's documentation just isn't clear? Well, that's where CDI comes in, acting as the collaborative bridge between coders and physicians. They jump into action whenever the documentation is incomplete, conflicting, ambiguous, or just clinically unsupported.
For example, if a chest x-ray shows bilateral infiltrates and the patient is receiving IV antibiotics, but the progress note just casually mentions possible pneumonia, a CDI specialist is going to prompt a formal query to pin down the exact diagnosis and organism.
Here's a perfect real-world example of how that works. A simple, compliant, multiple-choice query can transform a vague, low-paying term like CHF into something highly precise like acute on chronic systolic heart failure. Getting to this level of specificity is exactly how you rescue a case from getting dumped into an unspecified DRG, ensuring the hospital actually gets paid for the high severity of illness they are managing.
Section 5. High-stakes coding scenarios.
Now we have to talk about strict sequencing rules because they dictate your principal diagnosis. Take the sepsis rule, for instance. If sepsis is present on admission, and it's the reason the patient was admitted, that sepsis code must always act as the principal diagnosis. And this holds true even if you know the exact source of the infection, like a UTI. The underlying systemic disease is what dictates the principal code.
And when we're dealing with these top-tier drivers, specificity is absolutely everything. For sepsis, you have got to document organ failure to code for septic shock, which gets you that MCC. For heart failure, we need to know, is it systolic or diastolic, acute or chronic? With diabetes, you can't just jot down type 2. You need the manifestations, like DKA. Without this granular, detailed level of specificity in the daily progress notes and discharge summaries, these incredibly complex conditions just default right back down to lower-paying base DRGs.
Section 6. Procedural nuances and updates. Shifting to the surgical side, what's really interesting here is the vital distinction in ICD-10 PCS between an excision and a resection. The whole thing hinges on whether a portion or the entire body part is removed, but here's the catch. A body part isn't always a whole organ. For example, the right middle lobe of the lung is actually considered its own distinct body part in PCS. Therefore, if the entire right middle lung lobe is removed, it is coded as a full resection, not an excision. The exact same logic applies to something like a total prostatectomy versus a transurethral resection that only takes out a symptomatic portion. Grounding our procedural updates in anatomy, let's look at the newly introduced IPDRG 209 for complex aortic arch procedures. This update combines highly specific restriction procedures, think percutaneous fenestrated devices, and bypass codes across distinct, numbered aortic zones. Capturing the exact anatomical zone and the specific device in your procedure coding is now a fundamental requirement to map correctly into this new surgical DRG. Ultimately, all of these mechanics we've talked about today, from navigating the DRG funnel to the strict sequencing guidelines and pushing those CDI queries, they all serve one primary, incredibly noble purpose. They ensure you are painting the true, accurate clinical picture of the patient. Reflecting the true severity of illness guarantees quality data, proper resource allocation, and most importantly, exceptional patient care in the future. So, as you head back to your charts today, I want you to ask yourself this. Are you capturing every single clinical clue, or are you leaving the puzzle unfinished? Think about it. Also, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Catch you in the next one.